Hi, my name is Alex Vaccaro. I'm a professor of spine surgery at Thomas Jefferson University.
I'm Rick Sasso. I'm from Indianapolis, Indiana, Indiana Spine Group, and Indiana University School of Medicine.
Hi, I'm Carlo Bellabarba. I'm a professor at the University of Washington and at Harborview Medical Center.
Chris Kepler. I'm also from Thomas Jefferson University in Philadelphia.
Guys, I want to start off by talking about an epidemic that I've seen in spinal trauma, and that's the increased incidence of geriatric fractures, particularly type 2 odontoid fractures. And we've evolved over the last 20 years in our treatment, and I've noticed a trend that we're much more aggressive surgically. Carlo, tell me why you think that's the case.
Well, I think in general, we've got a few articles that have been published over the course of the last few years that have demonstrated to us that patients can be, I think, that patients' outcomes and the success of treatment is actually better with operative intervention versus non-operative treatment.
Mortality?
Mortality's decreased, although I think it's always difficult to know because there's always a bit of a selection bias. Even the prospective studies that have been done, they're observational studies, right? So the patients who don't get operated on, someone could, I think, reasonably argue that the reason they don't get operated on is because perhaps they're more fragile and therefore they have a higher likelihood of having a greater mortality. But in terms of looking at the data, at least taking it at face value, mortality seems to be higher in patients who are treated non-operatively. In general, the success of surgery in terms of neck disability index, in terms of avoiding major complications, and generally in terms of quality of life, various quality of life measures tends to be better with patients who are treated operatively versus non-operatively.
Ricky, when I was a fellow and a resident, we were placing patients over the age of 70 in halos. Do you ever use a halo? And if not, why?
No, not at all, especially in elderly patients. It's probably one of the big changes from our training when most patients with type 2 odontoid fractures were placed in a halo. And we saw how they did for three months. And if they didn't heal, then we would operate on them. Now, placing especially elderly patients in a halo has an enormous complication rate. In fact, it's one of the few things that we know for sure about odontoid fractures is that we don't place elderly patients in a halo because of the high morbidity and mortality associated with halo use in older patients.
Great. Chris, Carlo mentioned the fact that maybe we have a selection bias, but some people use the argument if you have a frail 85-year-old who can't take care of themselves, if you place them in a collar or a halo, they'll get a decubiti. Do you think it would make more sense for that patient to perform a stabilization procedure so the patient can be in a soft collar for a day or two and then go back to the nursing home? What's your opinion?
Absolutely. We've seen plenty of patients over the past 3-4 years with repeated bounce backs come in, they get imaged, the ER physician panics, gets another CAT scan, we end up in the same place over and over and over. Whereas sort of a definitive treatment up front can very often kind of counteract that and get the patient on the road to recovery with very minimal use of a collar post-operatively. And I think that really is the main benefit of surgical treatment is allowing patients to begin the recovery phase of the injury earlier. The other thing as far as the selection bias is concerned, while there probably still is still was a selection bias in the studies that were done prospectively and using an observational method. That was mitigated somewhat by the fact that if you look at the distribution of cases within that study, different centers tended to treat the patients that walked in the door one way. And so that decreases the selection bias where some patients are treated surgically. For instance, at our institution in that study, almost every patient underwent surgery. University of Kansas, almost every patient walked in the door with an odontoid fracture was treated non-operatively. And so that mitigates the selection bias to some extent because you're not cherry picking.
Sure. When we were younger, we used to love doing an anterior exposure and placing 1 or 2 odontoid screws, but it becomes a little bit of a problem in the elderly patient. What is your preferred surgical technique when you think surgery is appropriate? Do you like an anterior screw, or would you favor a posterior stabilization procedure, Carlo?
Yeah, I will rarely, if ever, place an anterior screw. I guess I'll never say never, but place an anterior odontoid screw in a patient with a geriatric odontoid fracture. I would typically do a C1, C2 posterior fusion, whether you use transarticular screws or individual C1 lateral mass C2 screws. I think that depends on the patient's anatomy and preference, right? But the problem with using an anterior odontoid screw, there are several problems. First of all, osteoporotic patient. They tend to have comminution. A significant number of these patients are comminuted. I think you can draw an analogy from the hip fracture experience in orthopedics, where the majority of the stability of your construct comes from a solid reduction with compression across the fracture site. So if you have a situation where you have poor bone quality, and especially with a comminuted fracture, you can put the screw in the correct position and have reasonable fixation. But if you don't have a good, solid, compressed, reduced fracture, then you probably don't have a very stable construct. Now, if you add on top of that the fact that there can be some technical problems, such as the tendency to put the screw a little bit too anterior, remount the caudal fracture fragment anteriorly, and therefore you get a loss of fixation of the more caudal fragment. And then on top of that, the swallowing difficulties that elderly patients tend to be prone to. I think it's a procedure that's much more prone to complications and failure than the posterior procedure. Now, the last thing I want to say is that on top of all of that, most of these patients will have some degree of C1-2 arthrosis, right? They'll have limited motion already. What's the reason to do an anterior procedure is to try and do a direct fixation of the odontoid and avoid fusing C1-2 and preserve motion. But if you're dealing with patients who, first of all, tend to be older and already have arthrosis and loss of lateral rotation, and then secondly, typically have that as a predisposing factor to having an odontoid fracture. A significant number of patients who actually have an odontoid fracture, they're predisposed to having that fracture because of the arthrosis at C1-2. Then you're accepting substantial amount of increased risk of surgery without a tremendous amount of benefit.
Sure. So Ricky, I've decided now I'm going to take the patient to the operating room and I'm going to do a posterior C1, C2 fusion. And then I say to myself, what's the biggest complication from this procedure? Morbidity from harvesting iliac crest bone graft. Can I get away with not taking autologous bone graft? Is there ways of getting around that to even further minimize morbidity of surgery?
Yeah, I haven't harvested iliac crest bone graft for a C1, C2 fusion in years. And I've changed my technique significantly over the years. And in the old days, we'd harvest big bicortical or tricortical grafts and place them between the posterior arches of C1 and C2 and cable and wire those in a very elegant fashion. I don't do that at all anymore. With our techniques of placing lateral mass screws in C1, we actually expose the C1, C2 facet joint very well. And so my technique is that I actually decorticate the joint itself inside the C1, C2 joint, and then place either local bone graft or demineralized bone matrix or some sort of bone graft substitute actually into the C1, C2 joint.
Do you section the C2 root to access the joint?
Nope. Elevate the C2 nerve and we're able to. Now, it is important you absolutely mobilize the C2 nerve root, and that's all about how to safely put in a C1 lateral mass screws. You have to be able to mobilize the C2 nerve so you don't have all that venous bleeding. But if you mobilize the C2 nerve, you've got great access into the C1, C2 joint.
We have time for one more question, and I want to focus on one last topic, and that is the argument, if I treat this patient with benign neglect, and if the patient goes on to develop a pseudoarthrosis, what percentage do you think will come in at a later time due to hypertrophy of the callus causing compression and myelopathy, or further displacement causing a neurologic deficit? Chris, is that a real problem?
It is a real problem, and I think that benign neglect was always sort of, for some people, was the treatment of choice. I think when you start drilling down and following these patients, it ends up being a treatment strategy which is prone to much higher rates of failure than we ever suspected. With only a 1-year follow-up, we had a conversion from non-surgical to surgical treatment of 25%. So that's a quarter in the first year. Probably, other eventualities of non-operative treatment, such as callus formation and myelopathy, probably would drive that number even higher as you get further follow-up. So I think that benign neglect is not benign.
So I'd like to conclude, in my 28 years of treating spine patients, we've gone from taking patients with odontoid fractures, placing them in a halo, to almost universal acceptance that surgery should be considered to decrease the morbidity. mortality, as well as probably the cost of medicine. So I think that's where we're heading as a spinal community at the present time. And I want to thank all the guests for coming in.